It's now about 10 years since Donald Buggy and his team published that landmark paper looking at retrospective outcomes of patients, breast care patients who'd have paravertebral analgesia versus patients who had volatiles and opioids, and found a difference in long-term outcome. And that really was a landmark paper because it started the process of where we are now. And it's even more remarkable because it introduces a new concept, that of anaesthesia as an interaction with the disease process itself, rather than simply as either, rather sadly, the absence of awareness plus analgesia, or alternatively physiological manipulation to improve short-term outcome. So Donald's insight has led us to think that we may actually end up in a world of personalized anaesthesia, where we tailor our anaesthesia to the disease process itself, because it may well be interacting with our disease process. And it's launched a whole load of research, much of it lab-based, but some of it now becoming translational, and some of it having a clinical basis. And if you just stick in anaesthesia and cancer recurrence into PubMed and you look at the number of publications per year, you can see that it really is taking hold. It's a very topical subject right now. Not only has it spurned a lot of research, it's spurned this particular run of conferences. So this is the fourth such conference, the Global Perioperative Care Conference. So I've got to go to MD Anderson, which is the middle one. I've also been to Melbourne, Peter McCallum, and then more recently to the UMC Amsterdam. And with each conference, I get the sense that there is a real gaining momentum for the topic. But the question is, where are we now, and so what? So I think probably so quite a lot, actually. Now, I don't want to go over Vijay's talk, because I think he's going to expand on this quite a lot. But just to put things into perspective, there are potentially 22 million cases of new cases of cancer per year by 2030. Surgery still is the mainstay of treatment. 80% of patients are having surgery, and a lot of them will get it many times. And by 2030, that basically means 17 million patients per year are going to need operations. So the potential for impact with just a fairly small change in anaesthesia is absolutely massive. I think the aim of this conference now is to understand what can we do in the pre-assessment to understand the basis of the patient's disease. How can we interact early to alter the process of that disease? And what can we do perioperatively? And to improve two things. The first thing is the short-term return to intended oncological therapy, so the idea that we get the patient well as fast as possible so that they can carry on with whatever treatment was planned. Because these days, it's very common for patients to have multi-modality treatment. The whole idea that you're just going to have surgery then walk away is increasingly rare. And long-term outcomes. There are certain of us that are convinced that anaesthesia can impact long-term outcomes, and hopefully during the course of this conference you'll get to see much of the evidence that lies behind that belief.